I'm really proud to invite Professor Harald Walach, coming from Basel, and we will listen to a very interesting topic on immunology, on psychoneuroimmunology. So thank you for coming. We are very excited of this topic. Thank you.
Good afternoon, ladies and gentlemen. Thank you very much for having me here. And I must first apologize because I didn't realize that this was in English. So my slides are in German. And everybody who wants to have English slides, write an email to me and I will translate it for you and send it to you afterwards. And the rest, I hope you will be able to follow me anyway. So psychoneuroimmunology is my topic. And I would like to start with a quote from my favorite philosopher Leibniz: miracles happen by virtue of the soul. Miracles happen by virtue of the soul. And in order to illustrate that, I would like to present you with a story which happened to me when I was in Freiburg, where Roman Huber also is. I was there from 1992 to 2005, heading the group that evaluated complementary medicine. And at one day, I got a call from a guy who said, listen, we have a very, very, very interesting complementary treatment for cancer, and it is absolutely miraculous. And he sent me a full file of that treatment, having been produced in Argentina. And it was produced by a doctor who was a fan of cactuses. And in order to treat his cactuses and prevent them from getting lice and every sort of thing, he used homeopathic dilutions, very simple ones, like aconite D10, lachesis D12, sort of thing like that, 5 or 6 of them, and sprayed his cactuses. And these cactuses bloomed and were very nice. And once his neighbor had a dog who got cancer. And the neighbor came to him and said, well, listen, can I not have your miraculous thing which you use for your cactuses for my dog? Because he has cancer and I want to treat him. He gave it to him and the cancer went away. And that story made the round in Argentina, and suddenly everybody wanted to have that. And after a while, and this is not lying, I saw the picture in the newspaper. After a while, cancer patients lined up at the Ministry of Health, and I saw an air view picture, where there was a round of cancer patients around the ministry saying, we want this miracle treatment for us. What happened? It was a miracle treatment because it was imbued with a huge myth. And that myth created a lot of hope, and that huge hope created some other miracles, and suddenly patients were healed of their cancers. And that is what I'm dealing with. It's always about our soul, our psyche, interacting with our body. That is what psychoneuroimmunology is about. Now let me give you a few data. The first really interesting study was that one. It was published by Temel and colleagues in the New England Journal of Medicine in 2010, and it was only early palliative care for cancers that were metastasized, lung carcinoma metastasized. Patients were randomized to receive normal treatment or early palliative care, which meant less invasive treatment, a lot of talking, right? And what you see here is that this was actually quite effective. These are psychological measures: hospital anxiety, depression, scale depression, anxiety, and this is physical health questionnaire 9. And what you can see is that early palliative care reduced all these measures quite significantly against the standard treatment, but more interestingly, even survival changed. And you see, this is quite a long-term trial, right? After a while, all these patients died, but there was quite a long period where more patients survived. Why? Because they somehow felt better supported and their psyche seems to have done something here. Now, meanwhile, this is a very interesting topic I just did a research the other day and put stress and cancer in together and filtered meta-analysis. If you use this, you get more than 1,000 hits. If you filter meta-analysis, you get 274 hits. So this is a trending topic. And here is one of the first meta-analyses that meta-analyzed how psychosocial stress and cancer are related, both in mortality and incidence. Quite a lot of publications, 126 meanwhile, or at the time, and quite a huge number of participants. I've checked, there is no better one since then. And here you have the general outcome of that meta-analysis. What you can see is you get overall, you get in mortality, you get a roughly 30% improvement. It's all significant here. And what I find quite interesting is that if you have a longer follow-up, the effect even increases. And that when you look at people or persons who have a stress-prone personality that are somehow treated, you get a stronger effect here. The same is true for survival, although the effect is very small overall. But you can also see a couple of studies, if they're fully controlled for covariates, the effect is actually quite big. But these are only 2 studies. And the same is true for incidence. Also, the effect is not too large, but it is very significant. And you can also see a few moderators that are quite interesting. A more recent meta-analysis used work stress and cancer as a meta-analysis, which is quite a huge number of patients or people included here, more than 280,000. And what you see is for all cancers, there is a risk ratio of 1.17. So you have a 17% increased risk for people who have work stress, and this is for different cancers, so lung cancer, colorectal cancer, esophagus cancer. You have increased risk if the work stress is too high. There is no significant risk ratio for these cancers, breast cancer, prostata, and ovarian cancer. Now, mindfulness interventions try to boost the self-efficacy of patients, is trying to give patients some relaxation and some tools they can use themselves. And there have been quite a few studies now. This is one of the recent meta-analyses of mindfulness interventions published 2 years ago. 38 studies are included, and there are different conditions measured, but what you can see is that the mean standardized effect size is around half a standard deviation or a little bit below, and that is also true for follow-up. The best effects you find with anxiety. So what you see here is that interventions that try to bank on this, they are actually quite effective. So, oops, that was the wrong button. So what we see is that psychosocial load, we could call it, be it in the job, be it privately, that increases likelihood of getting cancer, likelihood of recurrence, or earlier mortality. And if there is some psychosocial support, that increases survival or a better quality of life. The point, the really important point is the very intimate connection between body and mind, or body and psyche, body and soul. We have an implicit dualism in medicine where you outsource psychology to psychologists and you treat only the body. That, I think, is one of the biggest mistakes one can make, because there is always a very intimate connection, and therefore we always have to look at physical and psychological problems together, whether it comes from the psychological side, where depression very often is due to nutritional problems or due to other things, or whether it comes from the physical side, where physical diseases like cancer often have a psychological component. So we always have to bring them together. And by psyche, I mean the inside of our human being, what we experience from the inside, our affects, our emotions, our thinking, and the outside is the material world. And I think they need to be combined in a kind of complementary view. So if you look at that slide, what do you see? Most people see a parrot first, right? In fact, it's a lady dressed up like a parrot, sitting on that log. So if you look here, the lady has her face here. These are the eyes. This is only painted on her forehead. This is the arm, this is the other arm, and these are the legs. So I use this to illustrate what I mean by complementarity. You have two things in one, and you have to see them together. So it's not useful to say there is either psyche or body. It's not a parrot or a lady, it's a lady dressed up as a parrot. And our mental system is intimately intertwined with our physical system. I use the term complementarity because it allows us for a dualistic phenomenology, so we can see these two sides and they are not identical. Our inner experience is not identical to what happens in our brain, but we can probably combine them in a monistic ontology. This is a term by Jung, unus mundus, one world, which can be differentiated into the soul or into the psyche and the body. That's a concept that comes also from Leibniz and from other philosophers of his time, like Spinoza. And I think it's useful because you do not have to commit to a dualistic ontology. You don't have to say the mind or the soul is separate from the body and they are two things. They're combined, but there might be a unitary reality beyond which we cannot access. That's just a proposal. So psychoneuroimmunology or psychoneuroendocrinology combines psychological, immunological, and endocrinological processes in all directions, because our brain also is responsible for our psyche, for what we experience. We have the endocrinological system, which organizes the internal communication, and we have the immune system, which is a kind of sense organ for alien reality, for the outside. And they are all working together, and they are all producing what we call disease or bodily symptoms. They work together because cytokines and the immune mediators in the body, they are sensed by the brain, and they also have endocrinological properties, as do hormones. They are also active as neurotransmitters, nearly all of them, and they are also immunologically active. And the same is true for neurotransmitters. They are not just neurotransmitters, they also have endocrine functions, and they work in relationship to immune cells. Psychoneuroimmunology has been formally founded, that is the myth, by Adrian Cohen in 1975, by repeating experiments that the Russians have actually invented some 20 years earlier. And what they did was they used rats and combined an aversive taste stimulus, saccharin, with an immunosuppression to the system. So this was a clearly classical conditioning paradigm, and they could show that afterwards only the taste stimulus produced immunosuppression. That was the founding of psychoneuroimmunology, because it could show that the immune system can be conditioned, it can learn. Meaning psychological stimuli can have an immunological effect without anything in between. That's probably also the basis for a lot of asthma and stuff that you can see. Now, this was one of the first really fascinating studies by Cohen and colleagues published in the New England Journal of Medicine, where medical students, nearly 400 medical students who were volunteers, were challenged with viruses, rhinoviruses. They were all infected by putting rhinoviruses up into their nose, and they were all learning for their final exams. But not everybody was ill. Only those who reported stress, they became ill. And that was quite an interesting, and it's still an interesting study because it hasn't been repeated to my knowledge, but it's quite an interesting piece of information. Now, you know that we have two stress axes. The first is the direct one, where we always evaluate whatever is the objective situation or the danger. And only then, and this depends on our resources, how we estimate our resources, and only then stress is activated via the epinephrine or adrenaline, which is something that activates the body and activates also the immune system. That activates the innate immune system. The consequences are, of course, metabolically to get more energy, to get more efficiency, and immunologically activation of the innate system to deal with any potential problem. Now, the second axis, you know as well, is the one that runs via our ACTH system, runs to the, now I'm missing my words, but you know what I mean. And then releases cortisol, which leads to a suppression of the immune system. That leads to a suppression and shifts the immune reaction towards a reduction of the native system towards the other system, which on a long term leads to suppression, and that can be quite dangerous because if it's not counteracted, it can lead to all kinds of immunological problems. The consequences of that is clear. These are late effects to save energy and to increase negative affect, which leads people to look for solutions. That is the actual psychological effect of that. And immunological, it's a suppression, which long-term is dangerous. Now we also have counter-regulation. One is the oxytocin system. And the oxytocin system is the affiliation system, which leads to an increase in vagal activation and to relaxation. That also modulates the amygdala activity, which is responsible for anxiety, depression, and increases, as I said, parasympathetic activity. That is one counter-regulation system, and the other one is not very well known normally. It is the anti-inflammatory reflex. Have you heard that? Anti-inflammatory reflex? Well, it works like this. This is a macrophage, an activated macrophage. Every activated macrophage expresses acetylcholine receptors. And if you activate the vagus nervous system, that communicates with acetylcholine. So if you have a strong vagal activation, acetylcholine is released and can inhibit inflammation locally. So this is the second system. So we have two systems, and they have to be balanced. So we have to balance a sympathetic activation by parasympathetic activation, and this is by acetylcholine inhibiting macrophages or activating macrophages. This leads to an inflammatory reaction. This leads to an inhibition of the inflammatory reaction. And The same is also true with the other system. The cortisol system leads to a negative feedback, via negative feedback to a suppression of the immune system, while the oxytocin system reduces this activation by vagal reactivation. Now, what you probably know is that cortisol is being received in the hypothalamus, in the hippocampus here, and produces memory effects in the hippocampus. It inhibits memory. So you often find that with people who have dramatic experiences or traumatic experiences that they don't remember. They have a kind of memory problem. But you also have the other way, that systemic or peripheral inflammation, pro-inflammatory cytokines, they are also sensed in the brain, and that leads together to fatigue, a problem with emotion regulation, and memory problems, and often withdrawal from social activities. You can also use that therapeutically, and this is a book that is only available in German. It was a book by patients who had suffered from cancer. These are 11 cases that have been treated by an imaginative treatment, whereby people imagine a safe place, then they imagine a symbol for their cancer, and they do all sorts of things with that cancer, but it's individualized. So it's like individualized chemotherapy, it's individualized psychotherapy for cancer. It was invented by Lösch, who already died. Unfortunately, he had a lot of cases like that and was on the verge of showing that in trials, but he didn't succeed of doing that because he died prematurely. The idea is that patients practice that, and those patients who do practice that, they actually profit quite a lot. These were the cases, and I know that there are quite a few more patients. So this is what I wanted to tell you. So I think you've probably seen that parasympathetic activation secure social connections and social relationships. They have a physical basis in down-regulating stress-associated reactions in the body, and therefore they are immensely therapeutic. These psychological processes, they interact with physical processes in both ways. So if bad communication is practiced, patients get into stress, they lose hope, they get into all sorts of problems. So the gist of that message is safe communication and psychological safeguarding of patients in communication and in settings will do a lot to improve their well-being, their social activity, and also their quality of life, and probably also the survival. Therefore, I think communication and social safety are immensely therapeutic, and I think that needs to be brought into the clinic. That is a very important message I wanted to give you. That is the end of what I wanted to tell you. Thank you very much for your attention. If you send me an email, you can have my slides very, very easily. And those of you who don't understand German, I promise to translate them for you. Just let me know.
Thank you very much. Yeah, you are perfect in the time. Thank you very much for your message, which is a very important message. It's going into the medical humanities, which is not only a question of practices in clinical practice. I think it should be introduced during teaching in university.
Yes.
At my time, there was no teaching about that. So that would be something which I do in the US. They are obliging students to learn literature to start into this medical medicine. So that would be a nice teaching course for universities as well. Do you have any questions? Yes.
I have one question, and I often have cancer patients who are, after their treatment, they are asking about stress and how they can improve it. And sometimes I have the feeling that they get pressured, that they have to lower their stress.
That's another type of meta-stress, right?
Yes. How can we deal with that?
That's a very good question. I'm not sure I can give you a very good answer. I think one of the important things is always take stress out of the system, and even if it's stress, to lower stress. And then it might be important to tell people, just don't worry. Don't worry about stress. Be as happy as you can in the state you are. Go out and do whatever helps you feel good. And that will lower stress. And I think all little things like gestures, like making people feel safe, that is the most important thing. And if they then want to do something themselves because they say, look, doctor, I want to be active, I want to do something, then things like mindfulness or relaxation techniques or physical exercise, which is actually very effective as well, might be useful. But I wouldn't do it the other way around. You know, I wouldn't say, you have to do something, otherwise you will die. Not a good idea.
May I comment on this?
Yeah, please.
This question. Now, sometimes it's paradox that sometimes the solution is the problem and the problem is the solution. So, if stress is the problem, we can put it the other way around. Maybe the stress is the solution. It helped you when you were a child to perform for whatever reason, and to understand why I am putting all that stress and then pacify that cause, that actual cause, gives you an understanding. And that understanding allows you to let loose. Because from the conditioning, if somebody has a lot of stress, there was a benefit in having that stress. So just getting rid of it might not be sufficient. To understand what was the benefit in it gives you the option to let it go finally.
Well, that is quite true. Thank you very much for that comment. And of course, there are many. Nowadays, stress is very subtle, right? Stress can be something very subtle. It can be stress about communication. Everybody wants to be in contact with me. I have to know everything. It takes some time to figure out in a patient what is actually stressing him out or her. It can sometimes be something that people think that is stressing them, and they are not even realizing what is the real stressor in their life. And that takes some talking, that takes some psychotherapeutic intervention, probably even.
I have a question regarding how you can put this into action in the daily practice, because this kind of therapy is very time-consuming, and it's difficult with the kind of billing system we have in Switzerland to speak for a long time with patients. I, for example, work as a surgeon, and even if I plan 1 hour for my patients, I'm always overdoing the time that the Krankenkasse, that the insurances will pay. So is there a way to be able to let this data be more known, to make some kind of lobbying in the new kind of TARMED and the new billing system we're going into, that will not allow us to spend more time with the patient, trying to let them feel safe, planning the treatment? Do you know about some kind
I know
of
what you're
movements?
saying, but I'm not sure I have a good solution for that, because it is, of course, the case that our system is intervention-centered, and it thinks that everything that is very expensive and costs a lot of money is good for patients. And things that don't cost a lot of money is not really something that should be supported. And talking or being present for patients is one of those. So I think one of the problems is systemic, and I don't know how to change that. It probably needs a lot of political intervention, lobbying, as you say, talking to the responsible people, in order to get this more across. And meanwhile, it's probably important that we realize the options that we have within whatever time we have. It's not always about time. It's sometimes about doing the right thing in the right moment, and that can be a very short thing. It can be a little touch. It can be a word not said. It can be a word said. And to sense what is important, it is probably important for ourselves to be in that space of presence and in that space of availability. We have the tendency to be here and thinking about this and doing this and thinking about what happened just now. But being present in the moment is very difficult. It needs some practice. And I always say we need a culture of consciousness far more than we have in our culture. And that needs some practice for everybody who wants to have that. Maybe half an hour mental hygiene every day. We have integrated about half an hour physical hygiene into our culture, like showering, washing hands, going to the toilet, Takes about half an hour a day. And I think we should take half an hour a day to do that for our mind as well. And once we do that, we get into a space of creativity as well, where we can realize what we can do with those 2 minutes which we have now. More I can't say.
If I may comment on this as well, yes.
Sure.
I have my own private practice, and I started off as a doctor there. My specialty is also in yoga therapy, in a broader sense. Initially, people were coming mainly with the expectation of them doing body postures, but that has changed. Indeed, as you said, mindfulness is very big, and some people come with a cancer diagnosis wishing to actually understand the reason behind their stresses. Some just wish to regulate their stress a bit better. And what I found is, and I'm coming to your question, sometimes it's not an hour of talking, it's actually 5 minutes teaching them a healthy way of breathing. So that has been, you mentioned mindfulness and all of that, which is big, and there is a lot of even online programs you can do. But even sitting with a patient and then explaining how, extending your exhalation can actually already influence the parasympathetic nervous system, and basic things, teaching them how to bring their breath down to the diaphragm and things like that they can bring into their daily life, has been very helpful, and I get good feedback, and it doesn't take a lot of time. So it's a small tool, but that the way of influencing the nervous system through breath, I find it very low threshold and easy to implement into a busy practice life.
Maybe I can add a small comment to that. Do we have that moment? Yeah? We have that moment. Okay. I used to teach doctors in a postgraduate training program, and one of them said, I want to do something about mindfulness, but I don't have the time. And so we asked her what she was doing. She was an osteopath, and she said, well, I have to wash my hands after each patient. And we said, okay, why don't you make that your exercise? So she did washing of hands between each patient very mindfully, observing her body, observing her feelings, observing her mind. And she did that for about a month and wrote a journal on that. It changed her practice completely. Just 2 minutes after each patient.
Okay, thank you. I think we have to respect the time.